Thank you all for joining us today for the next installment in the Grensbach Lear & Associates webinar series, Grateful Patient Programs, Engaging Leadership and Physicians in Patient Fundraising Programs. Today's webinar is co-presented by Bob Alsobrook, GG&A Senior Executive Vice President and Managing Director, Eric Reinhart, Senior Director of Development for Patients and Families at the Vanderbilt University Medical Center, and Dan Lohman, Senior Vice President, GG&A Philanthropic Analytics. Today's session will discuss Grateful Patient Programs and issues of training gift officers to meet patient prospects and their families. It will explore how to establish productive development relationships with medical staff and hospital leadership and tracking your progress. Our presenters welcome any questions that you have during today's session and will answer those questions in the time remaining at the end of the hour. To address a question to any of our presenters, please use the chat function on the right-hand side of your screen. Select all participants from the drop-down menu and send us your questions. Any questions we do not answer today will be addressed in a follow-up message we send next week. Tomorrow afternoon, we will send a recording of the session along with the presentation slides, as well as a short survey to gain your feedback. Thank you for joining us today, and I will now turn it over to Dan Lohman to get us started.
Thank you, Joan. I want to welcome everyone to today's webinar about Grateful Patient Programs and a continuation of our series on this topic. I'm delighted to be presenting with my colleagues, Eric Reinhart and Bob Alsobrook. Eric really is going to bring a level of detail to this that I think will add tremendous value about Vanderbilt's experience in their program. We'll talk more about that in a moment, and Bob's extensive experience on the management side of these sorts of programs. I wanted to introduce the topic first by going back in time a little bit. Last July, GG&A presented a webinar about Grateful Patient Programs from more of a strategic point of view about why these programs are important and what are the major topical areas that institutions need to think about and questions that need to be answered in terms of setting up a successful program. Today, we wanted to kind of take it to the next level, or at least a portion of the next level, which is really get into the day-to-day issues. It's easy to say you need a prospect management system and you need the support of your physicians to have a truly successful program. It's much harder to actually implement those things. And Eric, Bob, and I wanted to take this hour to dig into a couple of those key issues. We certainly can't touch on everything that must be considered. So we will talk about prospect management, staffing a Grateful Patient Program, the role of medical staff as well as gift officers in Grateful Patient Programs and how to engage them, how to identify patient prospects, how to manage all the data associated with a program like this, and again, what I think is really our highlight, Eric's experience as the architect over an 8-year period of a widespread and lauded program at Vanderbilt, which not only talks about the success that Eric has been able to achieve at Vanderbilt University Medical Center, but also, and perhaps just as importantly, some of the pitfalls, challenges that have been encountered and the learning curve and where some redirection was required. I do, despite everything I just said about being practical today, I wanted to back up a couple of levels in terms of detail and just spend a minute reiterating why patient programs are important in healthcare fundraising environments. I have a couple of data points that I want to share with you from the American Association of Medical Colleges. So this is referring primarily to medical schools and their associated teaching hospitals and independent teaching hospitals. On this slide, we're looking specifically at medical school donors on average from the period from 2005 to 2009 for which we have data. And as you can see, even to medical schools, not joint programs and teaching hospitals, which I'll come to in a minute, that more than a quarter of dollars raised have come from non-alumni individuals, many of whom have been patients or were recent patients at the affiliated organizations. That's obviously a significant chunk, and it's worth pointing out that medical school alumni and board members and other groups like that are a fairly known entity. There are usually programs in place to cultivate and communicate with those populations on a regular basis in pretty sophisticated ways. And there are also groups that don't grow that much. The number of medical school alumni grows at a known rate from year to year, and the number of board members tends not to change by more than 1 or 2 in any given year. Foundation and corporation support is generally declining based on data from AHP and AAMC, so that leaves patients as perhaps the largest and most untapped likely source of philanthropic support. If we take a look at the next slide, which is what are known as joint programs, teaching hospitals with medical schools as combined fundraising operations, those non-individual alumni go up to nearly 1/3 of the total. And when we look specifically at teaching hospitals, that number goes up to almost half of total funds raised in those teaching hospital environments over that 5-year period. I don't have in this presentation data for non-academic medical institutions and community hospitals and the like, although on data that I have seen from AHP, it suggests these numbers are even more pronounced on the individual side where there are no alumni. It's people in the community who value the services you're providing. And as a final note on why I think patients are important, no one knows better what you do well than the patients who've been in your care, and our ability to communicate that and translate that into a notion of philanthropic support, we believe is a compelling message. Before I turn it to Bob, I want to show you a slide that's deliberately a little complex, and what it represents is most, if not all, of the areas that we think require consideration and plug into a Grateful Patient program. We're going to touch on most of these today in one form or another with a particular focus on prospect identification, data tracking, and the role of leadership and physicians. But I still wanted to present this as almost the basis of a checklist as you think about how you want to launch a program, how you want to grow a program, how you want to enhance a program, that really all of these areas need their own tactical and strategic plan. With that, I want to turn the presentation over to my colleague, Bob Alsobrook, to talk about a number of these areas in some detail.
Thank you very much, Dan, and it's a pleasure to partner with my colleague, Dan, and our good friend and colleague Eric at Vanderbilt Medical Center. What I want to touch on just a bit before actually Dan and Eric go into some very important detail associated with Grateful Patient fundraising programs are some of, again, what we know to be the general principles and thoughts that are associated with successful Grateful Patient programs, considerations that are necessary in terms of thinking about how to manage Grateful Patient programs and operate them. Some of these points are likely to be familiar to any of those in this webinar who participated last July, but again, I just want to touch in some general ways on things that relate to managing Grateful Patient programs and talking a bit about visits and calls, detecting some signs of gratefulness and gratitude, if you will, and some general thoughts about engaging physicians in the Grateful Patient fundraising process. In terms of managing Grateful Patients, we see that it's quite important in so many cases to be sure that Grateful Patient programs are part of an integrated management operation of a development program, that it's very important to have Grateful Patient fundraising operate as a distinct program, but not a program that is isolated or in a silo. It's very important, we see, to have prospects segmented, Grateful Patient prospects segmented in order to guide the assignment of prospects to the right development program areas and development officers at the time these prospects are identified as prospects. In turn, then, Grateful Patients need to be managed systematically, and that the protocol receives the support of the institution's leadership. physicians and executive leadership, and that they actually have roles and they participate in the process quite directly in ways that their schedules can permit, and we all know how tight those schedules are. The protocol for managing grateful patients and prospects we have in that category of affiliation is best driven by having accurate and timely data. As we think about the key roles in terms of grateful patient programs, what you see in the slide in front of you now is basically the litany or the roster of all key players as it might be associated with the development program, because a grateful patient program really does touch each major functional area within a development program in a number of ways. And so you can see that, or you would experience that the institution CEO, the leader, really sets the tone and the direction for ensuring or helping to ensure or facilitate the participation of all other role players in a grateful patient program. It is quite important, we think, that whether you have a full-time, 100% FTE serving as a program administrator for the grateful patient program, that there is still someone who is dedicated or designated to help coordinate and facilitate the grateful patient program, and that there are programmatic strategies and protocols in place that will definitely ensure that there are pipelines into the annual giving program and the major gift program. Certainly, research has a very key and important role in terms of helping us triage out grateful patient programs, prospects to the respective program areas. One of the ways that we are looking at, if you will, triaging out or directing grateful patient prospects, and that Dan and others will talk about shortly, relate to ways that you can direct grateful patient programs based on the gift potential that is assessed or analyzed through various kinds of assessment or screening processes. And what we have in front of you now is just a real general sample of how to give consideration to engaging the key role players in a grateful patient programs by gift potential. And as you can see, starting at the very top tier where we're talking about $1 million or more, it's suggested that there's some interaction at some of the higher or highest levels of the institution itself, and that it moves through the scale, if you will, to ensure that all grateful patient prospects are managed programmatically within some area of the development program. So I wanted to just talk a little bit about visits and calls in terms of the kinds of things that we, in working with many of our clients, discuss and map out in terms of operations and procedures. But one of the things with regard to contacts with grateful patient programs relates to ensuring that we're keeping in mind that the grateful patient coordinator, if you will, is helping direct the prospect information to the right first contact, to the right development officer, to the right program area from the very outset. The timing and the type of contact that is considered to be applied, if you will, to a grateful patient prospect is typically determined by the grateful patient's association with the hospital, with the academic medical center, with the institution prior to the patient experience. If they're a lead volunteer, even perhaps a board member, but others whom the institution has a close relationship with, that's going to dictate a contact that is different from someone who's not yet necessarily been associated with the institution, other than as they would now be experiencing it as a patient. There's no question about the need for a very careful determination of whether a patient is visited while in the hospital. The objective of a first contact, in our view, is that it really has the intention of ensuring that you're establishing or deepening a relationship with the grateful patient prospect, indicating that we feel it's useful, it's important to convey that we're grateful that this patient has chosen our institution for their medical care. That said, we're also noting the importance of being very transparent about who we are when we're making the contact, that the representative of the institution always is clear about what his or her role is in the institution, whether they're the president of the hospital or a development officer for the hospital. We clearly represent what it is that we do for the institution. Giving some thought to some of the points that help us get an impression that somebody could be grateful, that there's gratitude associated with their interaction at the hospital, as I think we see it in the case of other development interactions with prospects. Tone and demeanor are really important indicators. There are certain, if you will, phrases or comments or indications that give to us some direction that there is potential here for deepening the relationship and at some appropriate point bringing that relationship to a gift interaction. They say the things that I suspect many of you hear and that you're looking for in terms of the patient indicates that he or she has someone who's involved in medicine or science. Perhaps they're in medical school or a practicing physician or a nurse or someone else in the healthcare profession. They specifically say they can't thank you and others at the hospital enough for the care that's been rendered to them. They make comments that note that the staff has been so accommodating. They indicate that they really have a desire, a hope that no one else has to experience what they've experienced with this illness, and they indicate, again, a hope or a desire that there's some opportunity for a cure to be found, the care to be improved, that there's some possibility of prevention being a part of the picture of the future in medicine. There's general expressions about the fact that the hospital, the medical school, as they see it, does marvelous things. It performs miracles, if you will, and they query as to how that's done. And then one of the comments that I think many of us all look for and attempt to be very prepared to be responsive to, and we hope physicians are, and we want to make sure that that's the case, is when they hear and we hear from a patient, is there something I can do to help? We know that that's an important indication about next steps. With regard to physicians, just a few points before turning it over to Dan. It likely goes without saying or emphasizing too very much to this group, but the engaging physicians in the Grateful Patient Program is critically important. And in order to effectively engage the right physicians in the process, we see that successful programs really have the endorsement, the support of the CEO or the executive leader of the institution, that grateful patient fundraising is appropriate, that it's an important part of the overall relationship environment with the institution, and that in fact there's an expectation that leadership has that physicians will be a key player in the process. That said, development officers, development program leaders need to keep in mind, and of course we do keep in mind, that rendering quality medical care is the most important thing in that medical setting. That's what is important to the leadership, that's what's important to the physicians, that's what's important to us as development officers, but we have to keep in perspective and put in context the role of philanthropy. Physicians, though, to participate and to be engaged, need to see that there's an incentive for them to participate and partner with development and in philanthropic initiatives. An incentive that connects to the work that they're doing at the hospital or in the medical school, and that, in fact, there is some overarching objective that their involvement will help enhance the quality of medical care that the institution provides. Let me go to the next slide here. Some of the things that we keep in mind as we want to think about engaging physicians involves perhaps forming a champion group, a group of champions, if you will, a physicians advocate group that works with development directly. And we think it is helpful to have those kinds of groupings, but there are many considerations that go into forming such a group, not entirely unlike what one considers when you're forming other volunteer groups, but as it relates to physicians, we think in terms of Grateful Patient Programs, it helps to start with a small group that is involving physicians who represent programs that are aligned with the hospital's priorities. We know, as we should when we're working with any volunteer group or group of champions, that when we bring them together and we get them involved, we better be ready to take their advice, not necessarily lock, stock, and barrel, but again, take it to the extent that they know that we're giving it full and respectful consideration. We have to respect those physicians' time and keep our efforts and interactions with them very focused and pointing to a clear set of objectives. When we are involving them, we certainly need to commit to them to keep them informed about what it is we're doing and how we're utilizing their input, and how we can also point to the successes that come about through that interaction. And so, again, I think a final point that I'll just spotlight is that as these physicians are helping us, as we would with donors and other volunteers, we need to recognize and express the appreciation and high regard we have for them helping us in this philanthropic process. And particularly as it relates to physicians, in many ways we think it's quite important and appropriate for the leader of the hospital or the medical school, the CEO, to clearly indicate his or her appreciation for those physicians being involved. Now I'm going to turn it over to Dan so he can continue providing some much-needed detail to this discussion, and he'll be followed by Eric.
Thanks, Bob. I wanted to take a few minutes to talk about two issues that relate to one another but are nevertheless distinct, broadly labeled prospect identification and data flow. Patient prospects generally come from three sources. When we get very lucky, they will self-identify and use some of the phrases that Bob described a moment ago, tell you that they want to help, may come right out and say, I'd like to make a gift for this sort of thing. To the extent that we can't bank on that and do have an important role in cultivating that discussion as opposed to simply processing those gifts, I would encourage you to consider how are you ultimately advertising the importance of philanthropy and patient philanthropy. Make sure that patients know that this is an option and something that is important to the healthcare organization. There are lots of hospitals that put this information in admission packets with a brochure in the rooms, in waiting areas, in the cafeteria. And there are a number of good examples of that kind of documentation. And this is where I'll say for the first of several times, talk to each other. There is a lot of value in speaking to other Grateful Patient Program directors and fundraisers who work with patients directly, and of course you know that, but even things like just simply sharing these kinds of printed materials or website materials, there's no need to reinvent the wheel. In some cases it just requires customization. Physician referral is another source. Physicians did not go to medical school for the most part to become fundraisers. Some are particularly good at it, many aren't particularly comfortable with it, and therefore require some training and education to make them comfortable so that they can be as effective at fundraising as they need to be and would like to be. A bit of a soapbox-like admonition, you're the fundraiser in these cases, and they're not. You, in many cases, have been doing this for a number of years. Anything that you can do from the development side to make physicians comfortable by arming them with information, preparing them for questions. Sometimes they need a script or role-playing exercises. They almost inevitably need formal training of sitting down with you or an outside resource, or both, to talk about what they should be saying, how they should identify prospects, and we do need to be very respectful of their time, because they frequently will have very little time to devote to this, even though they recognize that it's important. Development staff identification, I'm not going to belabor what you already know and what major gift and leadership annual giving and plan giving officers do every day, which is talking to people and looking for those sorts of cues. So I want to talk about it a little more from the technical perspective of screening and segmentation. The word screening tends to be used as it relates to what we might think of as formal prospect screening, a technical process that is set up, and I'll talk about that in some detail in just a moment. But I want to use the word screening here to mean something much broader, which is any process of taking a big list of patients and turning it into smaller lists that we can then devote different kinds of resources to. Screening ultimately has to acknowledge the fact that a large academic medical center may see 200,000, 300,000 inpatient patients each year, maybe 1 million or more outpatients. Even a small 35-bed rural facility may see thousands of patients each year. And the development staff is simply unable to talk to, mail to, regularly and closely and personally communicate with those kinds of numbers. Formal prospect screening typically is provided by an external provider, and there's a number of companies that do this. And its advantage is you can set up a system where, as often as hourly to once a year and everything in between, send off lists of patient names and addresses in a secure and HIPAA-compliant fashion to pull back information about where people work and certain assets that they may have and their philanthropic areas of past interest and that sort of thing. Most of these systems also provide a ranking as well to give you some guidance as to, is this person a major gift prospect or something lower or higher than that. Some of its downsides are on the technical side. You do have to set up a process, and that often involves engaging the managers of the hospital side patient system. It often requires engaging an external vendor and going through a HIPAA process and so forth. Perhaps those are all surmountable. The one that's harder to overcome is that this process by itself doesn't solve all the prospect identification processes. The data sources relied on by any of the external processes that I'm familiar with, they just miss people. Most often they miss elderly individuals who also happen to be the most likely to be hospital patients and the most likely to have higher capability. That's not to say they only miss elderly individuals or that they miss all elderly individuals, but if you've been retired for 10 years, don't have a particularly high public profile, an external process like this is likely to miss some of the assets that might be relevant, especially if that person, for example, has sold significant real estate and now may live in a smaller home or a retirement community, which has nothing to do with their wealth, it just has to do with their life situation. Demographic data appends are a process of adding information that may be a little more general, but we can get it on more people. So it comes usually from sources, companies like Experian or Axiom, and most of this data was designed for marketing purposes, why some people get one kind of junk mail and other people get a different kind. But it can pull in general information about, for example, saying people are in the top 10% of income earners nationally, fill in age, pull in home market value or marital status information. the value here is that you can get it on nearly everyone. These databases are huge, and we often see successful matches on 90% or more of a patient file. The downside is that they're somewhat nonspecific, that the top 10% of income earners nationally is about $125,000 a year, which especially in a expensive market doesn't make someone a major prospect. So it's really more of a pointer than anything else. And there are lots of internal processes, many of which are very valuable. I've only mentioned two here, pulling by zip code or internal VIP lists. There are many, many other internal processes as well. The upshot is it's often very inexpensive. You can implement it without external help. There are some downsides to that as well. On the zip code example, zip codes are big in most cases, and they cover a lot of geography that hasn't been organized by wealth capacity. It's been organized by how it's easy to deliver mail. And there are zip codes that are in part wealthy and in part not wealthy, and that by itself can lead to some false positives. Can also lead to some false negatives in the sense that there are lots of wealthy individuals who may live in a zip code that's on average not that wealthy. That can cause us to exclude people that we might otherwise want to be talking to. Another related piece, something I've encountered over the years, many organizations that have worked with zip code data have found, for example, if you're a second-tier hospital in your market, if there's a couple of leading academic medical centers that you compete with and you're in sort of the next band in terms of specialty areas where you excel or the general socioeconomic status of your patients, often those organizations' best donors don't come from the wealthiest areas that, in Chicago, the Winnetkas and the Lake Forest and the Barringtons and the Gold Coast of the world. These may be the wealthiest people in another band of suburbs, in the Elgins or the Ciceros, where they're still extremely affluent individuals, but it may have 1 0 less at the high end of capability, or they have a different sense of the influence they can have on these institutions. So it's worth considering. VIP list, I absolutely want to encourage you to think about. If you have a list of people who are important to you, existing donors, board members, alumni, people in the community you'd like to know if they were in the hospital, a mechanism to compare patient lists against those internally created lists. Again, none of these are perfect on their own. In conjunction with one another, they can be very powerful. From a data flow perspective, and I have to confess, there is no webinar, no matter how long, that could cover all of the possible issues here. So as an introduction to that topic, I've listed just 6 common sources of information that you may have about any one prospect, from the various places where a name may show up on your radar screen and ultimately have to be connected to other information. For all kinds of reasons, there's some value in trying to get the key information in one place, but we have to be thoughtful. So first, if we talk about the practical idea of having all the data in one place, if we have patient census information, who's in the hospital right now or who has been here in the last month, we would then want to combine that with information we know about current donors and assigned prospects, with external screening information about wealth and capacity, to know if they've been suggested or referred by a physician as a potential prospect, and then some of the less intriguing but still important components, things like, are these people in a debt collection program with the hospital? Are they involved in a lawsuit with the hospital? Have they died, which is relevant. You don't necessarily want to make that phone call unless you've thought about it first. All of those things need to be taken into account. And there's a number of ways to handle this. Donor management systems are a great place for managing donors and prospects, but it's probably not a great place to just load patient names until they've been qualified in one form or another. One of the key issues there is HIPAA related. If we load lots of patient names into a widely accessible donor database that many people throughout the organization can see, we may run afoul of our ability to protect that information in terms of its distribution. So that's a critical feature. Plus, we wind up with a lot of data in records in the database that really aren't prospects or going to be donors. I encourage you to consider a bridge system. Eric will talk a little bit about Vanderbilt's use here, but lots of organizations have set up sometimes a simple system in an Access database, or in other cases more complex systems that allow you to join information from multiple places. So we've got patient data over here and screening data over here and physician information over here and risk management and HIPAA data over here, and it puts it all in one place that only a handful of people have access to that you can control. Finally, a couple of things to keep in mind. One is a technical issue of deduplication from a couple different sources. If you're screening every day or every month, it's likely that you'll see the same patient repeatedly, and it is worth talking to the hospital side database administrators to see if you can suppress or flag repeat visitors. And also that has implications for things like well screening of do you want to continuously reflag people you may have identified earlier. In visits from multiple family members, we see this a lot in children's hospitals where the guarantor may be the mother in one case and the father in another case for two different children, but it's really one prospect household, and trying to flag based on last names and addresses can be valuable. And certainly people who are already donors or alumni or have other affiliations with the institution. Deceased appending or determining people who may have passed away. I don't want to suggest that deceased records, or their families more accurately, are bad prospects, because in a lot of cases they're not bad prospects. They might be tremendously grateful for good care that you've provided, but the approach is obviously different and the language that we use. And then my last broad category of people who don't want to talk to you and vice versa, I won't read you the list, but thinking about exclusions and people where you may not want to put any resources, and it's better just to leave them out of the program. I want to turn the discussion over to Eric now to talk about Vanderbilt's experience, and as promised, I think it's the real highlight here to give you a real sense of how this can be implemented and tracked and managed. So Eric.
Great. Thank you, Dan. I want to thank Bob and Dan for the opportunity to be part of this today, and for all the participants that are sitting in on this. I've probably spoken to several of you and have stolen your ideas wholesale, and so thank you. I also have to acknowledge that this process I'm talking about requires multiple individuals, and so any results I share today are due to hard work, talent, and the diligence of those folks I have the honor of working with each day here at Vanderbilt. I'm not ready to call this a success, but what I do have to share is a very rational system that I think is helpful. Next slide, please. Just to give you an idea of how the Grateful Patient Program staff is organized here at Vanderbilt, this is a new development that we put into place, I guess, last summer. We've, over the last 7 years, kind of wandered about in the organization, trying to understand exactly what the role and place of the program was within the current organizational structure. And as the organization and the development office changed, we finally found our home, and I think this is working pretty well for us. We have 4 FTEs. I'm the program director. We have, I have some really talented colleagues working with me. The assistant program director has been a great addition. She has a history and talent and skill in information management and maintaining systems, and that was a resource I needed to have close at hand and not necessarily dependent upon a shared resource for that. So that really accelerated what we were able to do. The 2 other individuals are the development coordinator and the program assistant, and assigning FTEs to 2 distinct tracks of discovery, faculty referrals and faculty relationships, and then outright pure discovery, wealth screening, and people identified through wealth screening has accelerated what we're able to do. Next slide. This is, of course, the donor cycle that so many are familiar with, and I'm just putting it here to indicate that we're focusing primarily on the identification in the program. We're trying to pick names out of a hat, and it's a very large hat with 1.2 million clinic visits each year and about 45,000 inpatient admissions. And we want to pull these people out according to their capacity and then discover and discern their interest and move forward with that by adding them to portfolios and going on through the cycle. Next slide. And for today's presentation and for the design we're going to highlight this morning, the portion of identification that we are focusing on is physicians, nurses, and staff, the individuals within the healthcare setting that are having contact with patients and families, developing those relationships and bringing those people into our discovery pipeline if our preliminary research indicates that they have the wealth capacity to be significant donors. The other is the straight wealth screening track. And you'll see the other two. Direct mail, I think, is our next big step to develop, and our facilitated patient services are really those VIP-type concierge services and getting people at a very high level there. We've made some good steps toward integrating our data flow and our working relationships with that group. So next step, next slide. Like I said, we've been in place for about 7 years, but we did a major reorganization last fiscal year, and it required a national benchmarking, internal interviews with all the stakeholders in development, and some folks who just partner with the development but aren't part of the organization in any formal sense, and making sure our design aligned the incentives of all the different parties involved, and that's critical if you're going to have a pipeline and activities that are integrated across the substructures in the program, different teams, different roles and responsibilities. We're organized on a department and disease-based beat where development officers have primary responsibilities to particular departments. And so some of our discovery activities are really at a more general level, and that means that people with no known affiliation or affinity for any disease or department are going to be visited by development officers who have other responsibilities that are aligned with the department. But we conceived of ourselves as helping gift officers meet their goals. And if we could make their work easier, help them achieve their goals, we felt like we would be successful, and that's been a guiding principle. The other is that we wanted to make sure that our data systems allowed us to document each step of the process accurately. And we do, as a matter of fact, put patient names in our donor database, contrary to what Dan was suggesting earlier. We do it in a very limited way, and it's mixed in with other individuals that you really can't tell they're patients, and there is no clinical information that's in there. But doing that in a database of record allows us to report, and I'll show you in the culminating slide what that really leads to. It allows us to make sure activity on each and every individual is moving according to a protocol. And there are standardized activities that allow us to measure the operation or the activity and gauge those against what our requirements are, so we can innovate and make decisions that are pretty consistent across all emerging situations. So accurate measurement is dependent upon good documentation. We've pulled that documentation piece into the Grateful Patient Program, and we do not require or ask development officers or their staff to do any documentation any longer. You could talk to them. It was quite onerous, and not only is documentation improved, our measurements improved, and people are happier. So we don't want to burden gift officers. We want it to be turnkey so they can focus on seeing people. And like I said, we consolidated the documentation, and that's within the database of record. We use Advance here. We do that within the patient program. And that leads to being able to measure, to identify key drivers, our key indicators, and to look at outcomes. And that supports analysis and allows us to continuously redesign the program. And we'll get a little more specific, I believe, in the next slide. we're talking physicians, nurses, and staff as one track, and wealth screening as another, with an FTE assigned to each. This begins with us evaluating screening and visit data. We have access a limited view allowed by the HIPAA office, the privacy office, on the electronic data warehouse within the medical center. And we also have, through business objects, access the advanced data warehouse, which has donor information and where the screening data for DonorScape is kept. We pull these together on a monthly basis through an Access database that combines this information, and we apply decision rules based upon wealth capacity and some what we call affinity data, affinity information, which is really visit frequency and types of visits, to try to evaluate who are the people that we should contact this month. We have a very tight schedule. We try to be very rational and consistent in how we select people to receive a letter from the Associate Vice Chancellor of Health Affairs, which informs them that we'd like to thank them for receiving their care here, but lets them know that philanthropy is part of what makes our mission possible, and we would like to speak with them about their experience here and their interest in supporting our mission. So we're very upfront about the specific reason for which a development officer is going to be contacting them. Those letters go out, and then our program has someone that will follow up with a phone call and request that visit. And we used to send that letter out and wait maybe 5 to 7 business days. Sometimes it was longer, and the longer it takes to make that follow-up phone call, the less likely it is that a visit's going to be scheduled. Now we're doing that about 3 to 4 days after the letter goes out, and we're speaking with a lot more people. The program staff have access to all the gift officers' schedules and can schedule these visits directly into their calendars. We select the development officers that will receive a visit based upon a monthly report that ranks the available capacity in each development officer's portfolio. So someone who's needing additional prospects in their portfolio would be at the top of the list and so forth on down. And that's the capacity queue. We develop we have a information packet that's available for the gift officer. We place it on their desk with some information, any information gleaned from the scheduling phone call. And the gift officer goes out and makes the call and comes back and reports and really evaluates whether this individual should be added to the portfolio for additional cultivation. And repeat next month and repeat the next month. Next slide. Going back to how we conceive this, I'm just showing this, the next 3 slides really are indicating that we used Visio process diagrams very heavily in the design of this because we wanted to be very clear about what the responsibility and who had the responsibility for each step in this process, how it was going to be documented, who was going to be documented. And that allowed us to really minimize dropped handoffs, ambiguous relationships, ambiguous roles, and not have to kind of redecide how we were going to do something each time. Next slide, please. This is the diagram for the wealth screening process track, and I'll only note here that that green can at the top, if you go out to the left, it says to Principal Gifts Committee. We have a team that if someone has appears to be rated at $1 million or more, they're referred to this group of individuals who decide how we assume that these individuals need a specialized strategy, and they'll review these people for placement into portfolios, and we watch those very closely. Otherwise, you go through this process, and it looks like what I just summarized before. The next slide, please. And this is the process for the faculty referrals. I won't go into that, but when you receive the slides later, you can look at that. But I think that the detail in asking the questions and understanding the consequences of doing things a particular way were very helpful in really turning the key on this program and letting people do their work. Next slide, please. The pipeline, the idea of pipeline has always been kind of abstract in my experience, and I feel really positive that what you're seeing here is a pipeline that's very explicit. It's documenting the steps along the way. Each of the individuals on the program that have responsibility for the welt screening pathway or the faculty physician pathway maintain their work in a spreadsheet that is exactly what you see in front of you. And that allows us to track the source of the referral, which development officer made the referral date, the involved faculty, whether we discovered something after they were identified, and that means we should just kind of throw them back in the pool and catch them next time through the system, or we discover something that says do not ever refer this individual again. The qualifying piece in that, the cue, is that primarily when we are working with faculty, they'll say, you know, it's really not the right time to be contacting this individual. Why don't you contact me again in 3 months and we'll see if it's time for a letter. And so that lets us know how many people are kind of in a holding pattern. I have to say here as an aside that the previous process drove everything through the faculty, and that meant we were getting much fewer letters out the door, a lot fewer visits. And so teasing these tracks apart and having a faculty development track and one that does not involve faculty, that's just getting requests for visits out the door, has really had a substantial impact on the gross number of visits we've been able to have with clinical prospects. Continuing down the pipeline, the letter date lets us know that the introduction letter has gone out the door, and the call date says that we've made a phone call and we've asked them for a visit. And you can see that the column headers down the row there to the point where there's a visit or there's not. We have a closeout letter that closes the cycle that says we've tried to contact you a couple of times unsuccessfully. Please contact me if you ever think I can be of assistance. And that letter actually seems to do quite well in getting callbacks for people who are keenly interested in having a visit. The Extra Touches is a communication program we've recently put into place just to keep our names and the institution in front of people who were warm to what we were talking about but unwilling to schedule a visit at that time. Maintaining this gives us really great reporting capability. There's a manual version of this that each of the staff members maintains, and we also have a business objects version that I can produce on demand. And that has opened up the ability to do some reporting and analysis that we were unable to do before. The next slide, please. And this is it. This is a dashboard that some folks here would say I've been too excited about, but it really summarizes the activity and allows us to ask new kinds of questions about the efficacy of our efforts. The top row of graphs represents the faculty referral and faculty development track, and the lower row is the screening-based referrals. And you have data going back here to 2009, so 2.5 years of data. Now in the top row, you'll see in the first one, the faculty referrals are actually down this year. Some of that is due to the fact that we've changed the way we measure things, and there were some small lunch and learn events that were going into faculty referrals before. But I do believe the faculty referrals are down somewhat this year, and we're trying to figure out why. And now we can look at the measurement and say we need to look at that. But our new design is getting more faculty introductory letters out the door, and that's a good thing. And in the final graph, you'll see that the actual scheduled visits is a bit lower. So we're trying to figure out why that would be. Are we getting poorer quality referrals as faculty begin to increase more? Or are there some outlier faculty that are affecting our outcomes? A key metric or a key indicator for us is that little lavender square in the top right says RFA to visit, 16%. That's our ratio of requests for activity, which is our language for a request for a visit, to actual visits scheduled, and it's at 16%. It's down significantly from last year, but we think we're isolating some reasons why that is. I think the takeaway is that we're measuring this and able to ask that question. The next row is screening-based referrals. Remember, previously we would screen folks, and we would still ask for faculty approval before we sent them a letter, and the letter usually went out from the faculty member, and that was an obstacle. We've taken that away, and we have full control of the letters going out the door. They're signed over the Vice Chancellor of Health Affairs' signature, and you can see a significant increase and a threefold increase in the gross number of visits scheduled in that far right graph, visits from screening results. And the ratio there is 7.8%, which is pretty consistent with what we were doing before. It's just more of it. And that was the high volume encounter-based discovery process that we felt like we needed to put into place in order to achieve our targets. The bottom part of the dashboard on the left is just some key results that I'm able to provide quarterly that shows the results and summarizes the results. And that can change according to what leadership and managers are interested in. The bottom one is very interesting. It's the gifts closed or documented closures and closed gifts, and those are this current year, which is not necessarily connected to the activity in the current fiscal year. Those take some time to occur. But we're seeing that bequests are way overrepresented in our gift mix there. So that's fodder for thought. And you see the results and gifts closed that are related to, that are patients. We define it pretty narrowly here, and so we wanted to always keep the numbers we're reporting for patient fundraising connected to a defined subset so that our resulting dollars were as closely connected to the activities that we were undertaking in the program as possible. And that's always being refined. Again, it's the work of the gift officers that make all this stuff in this square and this graph happen. And I think that's all I have to say about this, and look forward to questions.
Eric, thanks for all of that information. That's terrific. We do have time to take some questions. The first one's actually for you, Eric. It's can you elaborate a little bit on how the Vanderbilt patient program developed its relationships with the doctors for the faculty referrals?
Yes, Bob was right on it with, it took a group of physicians, of department chairs that were interested in this to really get this going. And we worked closely with a group called Advancement Resources and held a series of faculty workshops over 2 or 3 years to engage leadership and then faculty, physicians, and advanced practice nurses who had more contact with the patients, and followed up with every one of those participants to get their feedback, to gather referrals, to begin to get them to participate and find a comfort zone within this kind of work, and follow that very closely. I think it's critical for leadership to say it's important to them. It's important to incentivize the faculty, and we're really discovering or exploring right now how we can incentivize the faculty to be involved in this.
Thanks, Eric. Keep in mind, if any of you in the audience have questions, you can submit them through the chat function in the control panel. We have another question. Does Vanderbilt visit inpatients while they're in the hospital?
No. I have done that. In my first weeks here, I did that, and my assessment of that was people do not look nor do they feel their best when they're in the hospital. And I gave that up after about 3 or 4 months of doing that. And we do have a relationship and a more formal relationship with the Facilitated Patient Services function here that allows us to do some of that for development purposes. But I wouldn't call that on a wholesale level a very important part of our program.
Thanks, Eric. one other question, which I'll comment on, and Eric and Bob, you may want to elaborate on it. What are the major HIPAA and privacy concerns related to Grateful Patient Program fundraising, and specifically, what do you do if you've encountered hospital leadership who are resistant for fear of HIPAA? I guess if you ask the question, you have to answer it, right? I think that it's really a question of process at this point. Do your homework, work with your HIPAA compliance people, make sure that you are well inside the spirit of HIPAA and its related act called HITECH, not just the letter of it. And in terms of getting buy-in, my strongest suggestion is do a little internal benchmarking. Call around to other institutions that you view as your peers or aspirational institutions, and if they're doing things like this, it becomes much easier to justify that this is something that's widespread, a good practice, and is something that you may be able to move that along. Did you want to add anything to that, Eric or Bob?
I think exactly. I think that's the most important strategy, if you will, is to demonstrate that many other institutions are doing this quite successfully.
There are a number of other questions, but we are coming close to our end of the hour. So our plan, as we do with all of these webinars, is to take any questions that have been submitted already or any that you can email to us. And in the next several days, Bob, Eric, and I will be back in touch with you with answers to those in a written format via email. Thanks for your participation. I want to turn it back to Joan for just some closing remarks.
Yeah, thanks so much for joining us today, and thank you, Eric and Bob and Dan, for that presentation. And we'll be following up with all of our attendees with the recording and the slides and the answers to those questions that Dan just described. So thank you for attending, and we hope you enjoyed.